Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is CY24 Final Rules. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any additional questions. We will respond to questions posed after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of this webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Good morning. We have a lot of material to cover for you today related to various rules that have been published in the last week or so by the Centers for Medicare and Medicaid Services. You can see from the agenda that we have a lot to cover. So we're going to go through this and try to address the key issues. Although you're probably going to see that we have some slides that you're going to have content. We're not going to go into a lot of detail on those as we move forward. So let's start with the end-stage renal disease prospective payment system final rule. This is going to apply to both freestanding and hospital-based dialysis facilities. There will be an increase in the payment rate of about $5 to $6. The fixed dollar loss thresholds that are used to determine whether or not a case qualifies as an outlier, they are being reduced significantly for pediatric beneficiaries, but also a slight decrease in the threshold for adults as well. Under the low volume payment adjuster, one thing that is important to note is that this is being made permanent to allow those facilities that have to close temporarily because of an emergency or disaster to continue to receive the low volume payment adjustment. And additionally, if you wind up having to take additional patients because another facility had to close because of an emergency or disaster, you also will be able to continue to receive your add-on payment. Facilities are going to be required to report time on machine as of January 1, 2025. The intent behind this is to better address resource use. Few additional payment changes that are identified on this slide. I'm not going to go into detail on those right now, other than to mention that beginning again January 1, 2025, dialysis facilities are going to have to report, as do hospitals, and as do hospitals for their outpatients, any wastage of drugs that are single-use packages and the entire package was not used. You would be reporting a JW modifier, and then if a JG modifier is required, that would be because you used the entire dosage of the single-use container. Finally, the ESRD Quality Incentive Program pretty much adopted exactly what had been proposed under the in the proposed rule that came out earlier this summer. A number of changes for payment year 2026 and 2027, again for both. This is as proposed. So with that, let's take a minute and look at the home health prospective payment system final rule. Under this particular program, one thing that's important to address is that the reductions to the program were not as significant as they were expected to be. This slide gives you an idea of the payment methodology for home health prospective payment system providers. The most important thing and what has caused some of the financial concerns related to home health is that national standardized 30-day period payment rate. Prior to the new payment model, we were on a 60-day payment cycle for home health services. Moving it to 30 days, there has been this discussion of whether or not payments have actually, or spending has gone up too much under this change in the program. So CMS has been focused on what kind of adjustments can we make. We expected that they were going to be making significant reductions because they had originally proposed a 2.2% reduction in the base payment amount. But what they are winding up doing is giving providers an overall approximately 0.8% increase in their rates. You've got the calculation that they did for this, but it doesn't mean that you're not going to get a cut later on. You can see that there was a 2.6% percentage point reduction that ties into the beginning of the PDGM payment methodology, the 30-day payment methodology, saying that there was more spend. What overall they expect that reduction needs to be about 5.6%. But they are only taking a portion of it this year. They are not saying when they will take the rest of it, merely that it will be applied in future years. From a payment perspective, a few other things that they have done in the final rule. They did reduce the labor share from 76.1 down to 74.9. As we would expect, the PDGM weights for each of the various groupings has been modified. And then a number of changes related to operations within the organization, such as payment for disposable devices used in negative pressure wound therapy, and regulations implementing payment for items and services under 2 new home health benefits that have been added. For the quality reporting program, again, very similar to what we mentioned earlier, they have essentially adopted those measures that were proposed, the discharge function score measures, where you begin publicly reporting in calendar year 2025, and the percent of patients who are up to date with COVID-19 measure. And then there are 3 measures that have been removed, also effective in calendar year 2025. This slide just gives you an idea as to the actual payment rates under the home health prospective payment system. And that the overall payment that you are looking at based upon whether or not you meet your quality reporting requirements. Under the value-based purchasing model, we have a number of measures that have been removed and the addition of 3 new measures for the home health program. And then last but not least, the refill policy for durable medical equipment. Essentially, it will require that for these refills, that the beneficiary has a confirmed need for a refill within a 30-day period prior to the end of the current supply, and you cannot deliver those DME items to the patient any sooner than 10 calendar days before the end of the current supply. Now we're going to get into a little bit of a controversial rule, and this is the outpatient prospective payment system final rule related to the 340B payment reduction that was taken by the Centers for Medicare and Medicaid Services for from 2018 to 2022. This slide gives you some background on the issue in terms of the litigation that addressed the fact that CMS, rather than paying for 340B acquired drugs at average sales price plus 6%, as they do for most drugs, separately payable drugs, they began paying for average sales price minus 22.5%. This was done in response to the fact that they felt that providers were being overpaid for 340B acquired drugs. This was taken to court and the providers were successful. Fortunately or unfortunately, CMS was given the opportunity to determine the remedy for the underpayment and the resulting overpayment, because at the same time that they reduced to average sales price minus 22.5, they increased the payment, and they added dollars into the base rate for all providers, whether they were 340B or not. Therefore, to fix this issue, they have to repay 340B providers, but they also have to take back that increase in the base rate that went to all providers. So we are now looking at an issue where we're going to be dealing with providers who are 340B providers, about 1,600 hospitals, who are going to receive a lump sum payment sometime in the first quarter of 2024. Total expenditure here is expected to be about $9 billion. That pays back the 340B providers. Now we have to deal with this conversion factor issue where there was an increase of 3.2% essentially in the conversion factor from 2018 to 2022. And the way they are going to address this issue is a reduction in your base rate beginning in 2026. They had proposed to do this beginning in 2025, but now it's going to be in 2026. For the next 16 years, there will be this 0.5% reduction from the base rate. Will not apply to new hospitals. So you can expect to see, unless there is something that fixes this in the interim, that beginning in 2026, your base payment amount under outpatient will go down automatically 0.5% to address this payment. Now, the one thing that is getting a lot of media attention on this issue is that in this final rule, CMS did not address Medicare Advantage. Many Medicare Advantage plans pay you as Medicare fee-for-service pays you, and therefore you would have gotten this reduced payment under 340B. You would have gotten an increase in your base rate. And for the next 16 years, beginning in 2026, you will have this reduction in your base rate going forward. Many providers in their comments said, what about Medicare Advantage? Do they have to do this? Do they have to pay back, et cetera, et cetera? And the response from CMS was, it's out of scope. We can't interfere with contracts between providers and payers. So this is an issue that individual providers are going to have to deal with moving forward as they contract again with the Medicare Advantage plans. With that, I'm going to take a quick look at the outpatient PPS final rule for calendar year 2024. Much of what they have done is as proposed. There is going to be a 3.1% increase in the payment rates for those hospitals meeting your quality reporting requirements, and the conversion factor essentially will go up to about 87.38 from the current 85.59. If you do not meet your quality reporting requirements, then you're going to have a much smaller increase in your base rate. Continuing to pay your separately payable drugs, including those acquired through the 340B program at average sales price plus 6%, and that they did continue with as proposed that beginning in 2025, you would report only the TB modifier rather than currently you can use JG or TB. You can transition at any time, but beginning in January of 2025, only the TB modifier will be allowed to re-identify those separately payable drugs that were acquired under the 340B program. As a provision of the Consolidated Appropriations Act, there was a behavioral health intensive outpatient program that is established, and the rules pertaining to that new program were included in this outpatient rule. It does apply to those beneficiaries needing a minimum of 9 hours of intensive behavioral health services per week, and it does require physician certification and redetermination at least every other month. It continues as proposed to apply to hospital outpatient departments, federally qualified health centers, RHCs and community mental health system centers. But one area that was addressed in the final rule based upon comments is they did clarify that substance use disorder services would be included in the scope of benefits for this program. It was not addressed as proposed, but it is included in this based upon the final rule. Site neutrality, this is an issue that we're going to see what Congress does with site neutrality between now and the end of the year. I doubt anything between now and November 17th, but they are moving forward with, for those of you who have intensive cardiac rehab services provided in a non-grandfathered off-campus hospital outpatient department, you have since 2016 received a reduction in these services, payment rate for these services. They are now going to bring you up to the full outpatient rate. This was an error on the part of CMS because those services, if they are provided in a physician's office, they are paid at 100% of OPPS. You were only getting 40%. They are bringing you back up to where you need to be.
Kathy, I smell a lawsuit brewing.
Oh, I do too. Absolutely. You betcha. I think it's ripe for those. If you did have off-campus cardiac rehab, you might want to talk to some good Medicare attorneys. Rural emergency hospitals, again, they did finalize the policy that was proposed, that Indian Health Service and tribal facilities that are interested in converting to rural emergency hospital status would be paid under their current all-inclusive rate. That would continue to be paid, as well as the REH monthly facility payment. This is our understanding of one of the main reasons that these facilities were hesitant to transition to REH status. They did adopt, as proposed, 4 quality measures for the REH program, but now, not yet. From a quality reporting perspective, the majority of what they proposed, they finalized 3 measures that they modified. They had proposed that they were going to remove the left without being seen measure. They did not do that. They're going to keep that in for now, but then they did adopt only 2 new measures. They did not adopt the hospital outpatient facility volume data on selected outpatient surgical procedures. So you've got the detail here in the slide on the various measures.
Yeah, and just FYI, I think we're up to 16 facilities that have converted over to REH since the beginning of the year. So it's not exactly a stampede to that new payment model, but we'll see how it develops.
And does that include the one that is closed?
And yeah, the first one to convert actually closed subsequent to conversion.
The last thing for me that I wanted to touch on that was included in the outpatient rule is price transparency. We've been waiting for this price transparency. What are they going to expect? They did, I think, as expected, move forward with their changes to the program. The display requirements have been modified. There is a CMS template layout that will be required, and certain items within the reporting have to be encoded. Therefore, as an example, hospital license number will go in this field. Hospital name will go in this field. And then they are asking that you include, or saying that you include on your machine readable file information on the rate type that you have negotiated with the payer. Are you being paid in dollars or percent? Is it some kind of a formula or algorithm that is being used? You're going to have to report the expected allowed amount based upon the contract. Information regarding whether or not these services were provided, whether this applies in an inpatient or an outpatient setting, codes, your CPT HCPCS codes and applicable modifiers. And then you're going to have a certain, footers specified by CMS. I don't know if this is good news or bad news, but they had proposed that you had to become compliant with these new requirements on March 1, 2024, they have given you a little bit of leeway in that requirements would not be, the changes would not be required until July 1 of 2024. They are going to require that someone within the administration of the facility certify to the completeness and accuracy of the machine readable file. And as they proposed, they are updating the enforcement provisions. They are going to have to acknowledge the receipt of a warning notice. You're going to have to provide additional information to assist in the assessment of compliance. They're going to work at the system level if they're concerned about individual hospitals within a system. And as we've seen them doing, they are going to be publicizing more and more information about the CMS reporting requirements. And there are detailed requirements for linking your transparency information on your website, and you're going to have to publicly attest to the completeness and accuracy of this information, again, on your website. So I think this is something that's going to take some time to review and to make some changes to what you've currently reported. With that, Martie, I turn it to you.
Let's talk fee schedule. When the rule was released last Thursday, the public inspection copy clocked in at about 2,700 pages. Obviously a lot of content to cover, but we'll just do what when in doubt, do a top 10 list, right? So we'll cover sort of the top 10 highlights from the fee schedule today. Our next Healthcare Regulatory Roundup will be a deep dive into the Medicare physician fee schedule by our colleagues Valerie Rock, Angie Caldwell, and Lori Foley. If you recall, this summer they did the same with the proposed rules, so you'll get that insider view on all of these provisions. But let's hit the highlights so that you're aware of what's going on. And of course, at the top of the list is the conversion factor. You know that to calculate payment under the physician fee schedule, you multiply the assigned RVUs for a particular service by the conversion factor. So if the conversion factor goes down, reimbursement goes down. And that's what we anticipate happening on January 1st of 2024. CMS has finalized a decrease of $1.15, or about 3.34% of the conversion factor, which will bring it to $32.74. Why, you ask? Certainly CMS received a stack of comments saying, don't do this. We cannot afford to reduce physician payments at this point in time. But CMS, their hands were tied effectively. The Consolidated Appropriations Act 2023, which actually gave us a bump in the fee schedule last year, required that this year, for 2024, that there be a 1.25% reduction. So that gets us 42 cents of the way there. The rest of the conversion factor reduction is attributable to budget neutrality. This is the other 73 cents. What budget neutrality requires is that the pie is set. Congress has a formula that determines how much it will spend on for payments under the Medicare physician fee schedule. And if CMS grows the number of services that it reimburses, or it adjusts the RVUs for services that it covers, it has to change the manner in which it cuts the pie. And the way it accomplishes that is adjusting the conversion factor. So this year, as we'll talk about next, CMS has finalized reimbursement for the office outpatient E&M complexity add-on code, G2211. Because the impact that will have, the new reimbursement that generates, that accounts for 90% of that budget neutrality adjustment. The other 10% is due to other new reimbursement and valuation changes, which are all relatively minor. But this is simply a reallocation of the Medicare physician fee schedule pie, that we're going to give more money to primary care physicians and we're going to take it away from proceduralists. It's just that simple. It's not that there's a cut across the board, that we're spending less under the fee schedule. We're just spending it differently with the change in the conversion factor.
Martie, quick question on that. Do you think Congress will step in and stop the cut that they mandated last year?
Me? No, I don't think they
Okay.
will.
Just wondered.
I mean, we'll see. They've got till, actually, we had 1 year where the rescission of the cut actually happened in January. So we don't have till, you know, it can go beyond December 31st, but I just don't know if there's the political will in Congress to do that right now. But I hope otherwise. I sincerely would be very pleased to see a reversion of the conversion factor. What really needs to happen is get us off this trail we've been on since MACRA. You know, before MACRA, we had the sustainable growth rate nightmare, which actually required congressional action every year. Then with MACRA back in 2016, we started down a new path. We just have to figure out how to correct all of it. So it's just a mess that we're going to live with until Congress steps in.
And just FYI, that is on MedPAC's agenda this year for a recommendation for how to fix this mess. This should be fun.
Exactly, exactly. Well, let's talk about the culprit or the savior, depending on your viewpoint, which is the complexity add-on code, G2211. You see there on the screen the CPT definition. You also see a quote from the final rule, CMS's explanation of why it moved forward with finalizing this reimbursement. Granted, CMS could have changed its mind and not implemented the add-on code. That would have probably resulted in about 65 cents more in the conversion factor, but they chose to go forward. And their reason is that this is the completion of their multi-year revisions to the E&M codes. And what CMS is pointing out is that there are proceduralists who are compensated for their extra skill by the reimbursement they receive for the procedures they perform. But we don't have a corresponding way to reimburse the medicine-based specialties, primary care and the like, for the work they do in managing a patient longitudinally. And so rather than creating a new separate set of E&M codes, we're simply going to put a kicker on the existing E&M codes for those types of services. So the rules for billing G2211 is to identify when you're providing longitudinal care. And actually CMS defines this by exception, that you are not providing longitudinal care if you do not intend to have an ongoing relationship with the patient, such as urgent care, consults, and second opinions. In those instances, it would not be appropriate to bill 2211. CMS also clarified that it will not pay 2211 when it's billed as an add-on to an E&M visit that has a 25 payment modifier on it. So those are the two instances when you cannot bill this code. The question then becomes, when can you bill the code? And CMS really intends that we assume, if it is not one of those two exceptions, that you are in fact providing longitudinal care, which involves additional effort and time, and thus we want to provide this complexity add-on code. CMS is not providing documentation guidelines on what needs to be reflected in the medical record. They've not commented in any way, shape, or form on that. They have identified that you can use this code when you're providing services via telehealth. What we do know is that CMS, in calculating the budget neutrality impact, assumed that for 2024, it would see 2211 attached to 38% of all E&M, outpatient office E&M codes in 2024, but it expects that number to eventually grow to 54%. So it's a pretty significant number of services they intend to reimburse this code for. The national payment rate for 2024 is just a smidge over $16 for this E&M code. Appreciate that's intended to offset the losses that primary care physicians will see due to the lower conversion factor. So if you have an opportunity to bill 2211 and you don't, you're leaving money on the table. And in fact, you're going to see that negative impact of the conversion factor reduction on your services. Next, let's talk about the big surprise in the Medicare physician fee schedule, which was the split shared visits. This has been just dragging us around again through this entire process of CMS revising the E&M codes. In 2023, CMS had, CMS had previously announced that it intended to determine under whose MPI a split shared visit should be billed based solely on time, how much time the physician spent versus the non-physician practitioner when they performed a service in a hospital setting, and they shared the provision of that service between the two of them. We would bill it under the MPI of who spent more time delivering that service. In 2023, CMS said we are going to delay a year. In 2024, they said we're going to delay, the 2024 proposed rule, excuse me, they said we're going to delay another year, the implementation of this new rule. And then surprise, in the 2024 final rule, they announced a whole new way of determining under whose MPI you're going to bill a split shared visit. They are finalizing that the substantive portion, i.e. who you bill under, is either going to be determined based on time, who spends more time, the physician or the MPP, or who performs the substantive part of the medical decision making. CMS made this change in the final rule based on revisions made to the code descriptor in the CPT manual. So they said, we're going to go along, we're going to follow AMA and what they've done with the CPT manual in terms of defining the appropriate billing for a split shared visit. What you see there in the quote at the end of this slide is the explanation offered by CPT of how you determine what constitutes the substantive portion of medical decision making. And as you'll see, it really hinges on who made or approved the management plan for that patient. And we certainly will parse that out in greater detail as we go to implementing this new rule for 2024. The final nail in the coffin to the appropriate use criteria is included in the 24 final rule. This had been mandated by PAMA back in 2014, that the idea was that if a practitioner is going to order an advanced diagnostic imaging service, they're going to be required to consult with some sort of clinical decision support mechanism to validate that that is an appropriate service. CMS announced in the proposed rule that it intended to pause its effort to implement this. And now in the final rule, it actually goes through several pages of explaining why it was simply impossible to implement this rule given the lack of necessary supportive technology. And so it is freezing out this program for now, provides no indication of when it intends to pick this back up, but certainly has offered Congress a lengthy explanation of its decision not to move forward. So good news here.
Prayers have been answered to a lot of providers.
Exactly. Let's spend some time talking about new reimbursement for services that address health-related social needs. There were 3 that were proposed, and we actually end up with 4 in the final rule, starting with the SDOH risk assessment, G0136. These are the actual, we now have the HCPCS codes. These all had X's in them in the proposed rule. This is reimbursement for the administration of standardized evidence-based SDOH risk assessments. Assuming that it takes about 5 to 15 minutes, we can do this no more than once every 6 months. The change from the proposed rule to the final rule, the proposed rule said that the assessment had to be completed on the same day as an E&M visit, where the practitioner determined the need for the assessment. Now, CMS is allowing that it does not have to be furnished on the same day, though generally we would not expect it to be performed prior to the visit. Because this is not intended as a screening tool, it is instead triggered when the practitioner says, hey, I think there's something going on here related to social determinants of health. I need to understand that because I believe it's interfering with my ability to diagnose or treat this patient. Thus, I'm going to perform this screening to identify those needs specifically. The assessment itself can be performed by auxiliary personnel if you meet the Incident 2 rules, and it can be performed via telehealth. It has been included in the telehealth list going forward. There are specific tools that you are to utilize in performing the screening. I assume most folks are going to end up using the CMS Accountable Health Communities tool, but there are the others listed here that have been approved by CMS. You are required to then document in the medical record what needs have been identified. You are encouraged to use the Z codes, but not required to use the Z codes. You see the payment rate relatively low for this, given the minimal time involved, about $19 for non-facility. For facility, it's about $9, but you do have the opportunity to bill the APC, which adds another $30 of reimbursement. Next up is Community Health Integration, or CHI services, G19 and 22. So there's been a movement over the last several years to create reimbursement for services provided by community health workers. About half of state Medicaid programs have a vehicle for such reimbursement. Between the American Rescue Plan and the Consolidated Appropriations Act of 2023, there's been just shy of about $300 million that have been appropriated for community health worker training. This now becomes the vehicle, CHI billing, to reimburse for community health worker services. We deliver this service, to provide this service and to bill for this service, we have to have a CHI initiating visit. So it's either an E&M visit, transitional care management, or an annual wellness visit. In the course of that visit, the billing practitioner is going to identify the presence of an SDOH that requires to be addressed because it's limiting the ability of the practitioner to either diagnose or treat the patient's condition. CMS notes that this initiating visit cannot be an ED visit, inpatient or observation visit in the hospital, or a skilled nursing facility E&M visit. Instead, it has to be more of the traditional office visit that provides that the basis of the initiating visit. Once you've, and of course, the initiating visit is separately reimbursable, but that is the green light then for certified or trained auxiliary staff to provide these services under the general supervision of the billing practitioner, very similar to how we do chronic care management services. You see the two codes there. One is the initial 60 minutes of services in a calendar month, followed then by each additional 30 minutes. And CMS notes that they put no frequency limitation on the G0022 code. So you can bill as many units as you can, as you provide services in a month for these services. And then you see the service elements, what you would anticipate that the community health worker or other qualified staff is providing under this particular code. Additionally, CMS requires that auxiliary personnel are documenting their activities, including the amount of time they spend in the billing practitioner's electronic health record. You should include in the documentation the specific SDOH that you're addressing and how it is intended to help resolve it. Only one practitioner can bill CHI services in a given month, so it's a race to who files the claim first, who will get paid. CMS had proposed not to require consent for CHI services, but it reversed course based on comments that it received, that you will either have to obtain oral or written consent following notification to the beneficiary of the cost sharing obligation, as well as the fact that only one practitioner can bill the services in a particular month. You are only required to obtain consent for CHI services once as opposed to annually. The service cannot be billed when the patient is under a home health plan of care. It can be billed in the same month as other care management services, provided there's no double counting, that the services are distinct, the time spent is distinct. The billing practitioner can make arrangements to have the CHI services furnished through a third party, like a community-based organization that has community health workers, but warns that there needs to be a sufficient level of clinical integration between that third party and the billing practitioner. Finally, you see the payment rates listed for these services. Again, the opportunity, if it's furnished through a hospital outpatient department, to bill the APC on the initial code for that additional reimbursement. Also note that CHI has been included under G0511, which is the code for which rural health clinics and federally qualified health centers bill care management services. Next up, the third type of reimbursement for SDOH is principal illness navigation, G0023 and 24. This is intended for those patients that have been diagnosed with a serious high-risk disease that has a certain level of acuity, as well as a need for ongoing monitoring. You'll see the PIN initiating visit is mirroring the requirements for CHI. You are also seeing this requirement for certified or trained auxiliary personnel furnishing the service under the general supervision of the billing practitioner. Again, the 60-minute code with the 30-minute add-on code, no frequency limitation, and again, on the screen are the specific service elements for PIN. Again, same as you see for CHI, you see for PIN in terms of how the services are documented, how often you can bill for this, that only one, oh, I'm sorry, I apologize. For PIN, there could be instances where you have two practitioners billing for the service, but very limited circumstances where one is addressing one condition and another is addressing a different condition through PIN services. Note also a consent requirement for PIN, but for some reason, CMS requires an annual re-up of this consent, not for CHI, but yes for PIN. And then, of course, you have the third-party billing issue we discussed previously. You see the payment rates there on the screen, and then also that is going to be added to G0511 for rural health clinics and federally qualified health centers. The new code added in the final rule is PIN peer support. So this is a particular type of PIN service delivered by peer support specialists. Two new codes here. It is limited to those beneficiaries with severe mental illness or substance use disorder. It is very similar to PIN, except we've tailored the scope of services to be consistent with the scope of practice with peer support specialists. Otherwise, you'll see it aligning with the PIN code itself. Well, let's switch gears and talk about what CMS has done with telehealth in the Medicare physician fee schedule for 2024. You have the adoption of policies that align with the telehealth extensions from the Consolidated Appropriations Act 23, which is effectively extending the waivers for the PHE through December 31st of 2024. Note also that CMS has finalized the regulations to address the inclusion of marriage and family therapists and mental health counselors in the providers who can furnish telehealth services. Regarding the telehealth services list, the types of service for which you can provide telehealth services, CMS used to have this very convoluted process of what was a Category 1 versus what's a Category 2 code, and then it created Category 3 during the pandemic. They've washed that away as they did in the proposed rule. We'll now have provisional and permanent. Provisional codes are simply those where we're still accumulating the evidence base versus permanent, where there is a sufficient evidence base to prove that it's effective delivered via telehealth. Effectively, CMS took all the extension of codes in during the course of the PHE, the Category 3 codes as well as others, and have moved those all to provisional. And provisional codes will not be removed from the list unless the evidence generation, as long as the evidence generation process remains in effect, unless there's an identified patient safety issue going forward. So good news there, pretty broad expansion of what can be a telehealth service on a permanent basis, even after 12/31/24, when the geographic and location restrictions go back into effect. Other on telehealth is we change the billing rules. We will begin using POS2 for telehealth provided in a location other than patient's home. POS10 when services are provided in the patient's home. You discontinue the use of the 95 modifier. POS2 is going to be paid at the non-facility rate, so the lower rate for those services, but for when you're providing services in the patient's home, we'll stay at the higher facility, we'll stay at the higher facility rate. We're suspending otherwise you can see on the screen the other allowances CMS has made for telehealth through 2024, as well as the increase in the originating site facility fee. CMS has provided in the physician fee schedule an opportunity for institutional staff to be, for hospitals to be reimbursed for services, certain services furnished by institutional staff. That includes outpatient therapy services, diabetes self-management training, and medical nutrition therapy. If these are furnished by institutional staff, they are reimbursed on the fee schedule. During the PHE, we allowed reimbursement when those services were delivered to patients in their homes. CMS, at the end of the PHE, said we're just going to discontinue that reimbursement. Now we're coming back in the 24 physician fee schedule and extending reimbursement for these services through the end of 2024, noting that we would apply the modifier 95 to each applicable claim line. Finally, under the subject of telehealth, CMS is extending direct supervision furnished virtually through the end of 2024. So what has typically been the direct supervision requirement of physically present in the same suite of offices and immediately available to provide assistance to meet the direct supervision standard for incident to billing, diagnostic testing, pulmonary rehab, and cardiac rehab, we will allow that to continue to be delivered virtually. Then at least for now, we can expect that to revert to physical presence at the beginning of 2025. We'll see what happens next year as we go through the rulemaking process. For remote patient monitoring, CMS goes through a number of clarifications, both with respect to remote therapeutic monitoring and remote physiologic monitoring. We will not go through these in detail here, but of course have the summary of those clarifications made by CMS. Most importantly, CMS admitting that in fact, for treatment management services, it does not require the 16-day of data collection. CMS is creating new reimbursement in the 24 final rule for caregiver trading services. This is a service where the patient is not directly involved, but because of the plan of care developed for the patient, the practitioner determines there is a need to train friends and family member on how to support the beneficiary. Again, you see here the specific codes that have been created, the reimbursement aligned with those codes. Noting that particularly on the 96202, that is intended to be a per beneficiary code when in fact you're delivering services for a larger group of individuals. So you may have beneficiaries, individuals representing 5, 6, 7 beneficiaries. You would bill that service per beneficiary. You see there the reimbursement per beneficiary. Under behavioral health services, a number of loose ends that CMS has tied up in the final rule in terms of implementing provisions from the Consolidated Appropriations Act that create coverage for marriage and family therapists and mental health counselors. These providers will now be allowed to enroll in the Medicare program. They will also be added to the list of RHC and FQHC practitioners. The payment changes for psychotherapy services, for crisis services. They are now permitting additional providers to furnish health and behavioral assessment and intervention. CMS is now beginning what will be a 4-year process of adjusting the RVUs for time behavioral health services. So we'll see those increase year over year. And now allowing general supervision for behavioral health services furnished incident to in an RHC or an FQHC. And finally, we have adjustments to the Medicare Diabetes Prevention Program. CMS initiated this in 2018. There have only been a few thousand claims filed for these services. So CMS is intent on refining the program to make it more user-friendly. That includes changes to the manner in which each session is reimbursed. Rather than clumping groups of sessions together and reimbursing, will now reimburse each session separately. And they will extend the PHE flexibilities that allow this service to be delivered via telehealth through 2027, but noting that those suppliers who furnish these services are still going to have to qualify for in-person recognition under the standards, in that the patient can elect to receive the services in person, and thus the provider has to be qualified to do so. Obviously, there's a lot more in this rule. Certainly the quality payment program changes, the Medicare Shared Saving Programs update, which are always part of the annual fee schedule rule. But you see here many other subjects that are addressed in that rule. Again, next up in our series, Healthcare Regulatory Roundup, will be a deeper dive into the fee schedule. We are still figuring out exactly the date. It'll probably be November 29th or that following Wednesday, but we will get that information out to you all as soon as possible. So thank you for joining us through a relatively quick review of what CMS has been up to in the last week and a half. We are anxious to see what they're going to do through the end of the year. But Kathy, we will certainly be watching what Congress is up to.
Absolutely.
Because they have a lot of work by the end of the year.
And absent any other breaking news between now and the end of the month, Marty and I want to wish you all a happy Thanksgiving and enjoy your time with friends and family.
Okay. Thanks so much. Caitlin, back to you.
Well, thanks so much to our presenters, Martie and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey. Later today, you will receive an email with their contact information and a recording of this webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website. You can find that at www.pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete that short survey and post any questions you may have. On behalf of PYA, thank you so much for joining us, and we hope you have a great rest of your day.